Welcome back to the deep dive. Today we're taking on a really critical mission. We're trying to cut through all the noise around psoriasis
hmm
because this isn't just, a surface level skin issue. It's a chronic, it's persistent, and honestly, it's a deeply misunderstood autoimmune condition.
It really is.
So our goal here is to really extract the core knowledge, to understand the hidden mechanisms, the 5 different ways it can show up, and, the whole management strategy you need to live well with it.
And to start, I think you have to grasp one foundational non-negotiable fact. Psoriasis is a systemic, an autoimmune illness.
Okay, so it's the immune system fighting the body.
Exactly. It's the immune system acting against the body. When your skin is healthy, skin cells are born, they mature, and they shed over this pretty leisurely cycle. About 28 to 30 days, that's just normal regeneration.
And that slow, steady turnover is what keeps our skin healthy and strong.
That's it. But with psoriasis, the immune system, specifically its T cells, well, and you slam on the accelerator, that 30-day process gets sped up dramatically.
How dramatically?
Your skin cells are rushing to the surface in just 3 to 4 days. And this overwhelming speed, it results in a buildup of immature cells, creating those dense, raised plaques that we see.
So psoriasis is defined by this T cell malfunction, which leads to uncontrolled, rapid skin cell growth, and then all the inflammation that comes with it.
You've got it.
And because we know that, we can just say this right up front. Psoriasis is chronic, it can come and go, but it is absolutely 100% not contagious.
So important to state that.
Okay, so let's drill down into that immune malfunction. If the T cells are the problem here, what exactly are they doing wrong?
Well, you can think of T cells as the military police of your body. Usually they are fantastic at identifying foreign invaders like a virus.
Right.
In psoriasis, they've gotten some faulty intelligence. They mistake healthy, normal skin cells for a massive threat, and they launch a full-scale attack against their own tissue.
So the body is mounting a defense against a problem that doesn't actually exist. What happens then?
That misdirected attack kicks off this huge inflammatory cascade. And it's not a passive thing, it's an active war. And it's fought with these powerful chemical signals. They're called cytokines.
I've heard of these. TNF-alpha, IL-17, IL-23.
Yes.
These aren't just letters and numbers, though. These are the immune system's like accelerator pedals for inflammation, aren't they?
Precisely. They are the chemical messengers, the signal flares that are screaming at the skin cells. Divide faster, grow now. And these signals flood the skin, they maintain that state of inflammation, and they drive the cellular machinery into that extreme overdrive.
And that's what results in those reddish, well-defined, silver-scaled plaques.
That's the end result of that whole process, a runaway train of cell production.
It's amazing. And speaking of context, the history of this is pretty fascinating. The term psoriasis comes from the Greek word psora, which means itch. And for centuries before we understood this whole autoimmune engine, its appearance led to these terrible misunderstandings. People even mistook it for leprosy.
And that historical context really helps us understand why knowing the specific types today is so crucial, because they vary so widely. I mean, psoriasis is truly a master of disguise.
All right, so we definitely need to spend some time on what you call the 5 faces of psoriasis. Let's start with the one that, 90% of people deal with.
That would be plaque psoriasis.
Yeah.
It's by far the most common, and it's characterized by those elevated, red, inflamed patches, the plaques, which are covered by that very distinctive silvery white scaling.
And they tend to show up in specific places.
They do. They favor areas prone to friction. So, the elbows, the knees, the lower back, and the scalp are very common spots.
Okay, then we have a form that's often linked to a specific infection, guttate psoriasis.
Guttate is really striking because it presents as all these tiny, scattered, drop-shaped lesions. The key feature here, as you said, is the trigger. It often follows a bacterial infection.
Like strep throat?
Most commonly strep throat. This makes it far more prevalent in children and young adults, and sometimes it can clear up completely once that underlying infection is gone.
Interesting. Okay, next up is the type that sort of hides and folds.
That's inverse psoriasis. And the location is really the main differentiator here. It happens in moist skin folds, like the armpits, the groin, under the breasts.
So it looks different, too.
It does. Because of the moisture and friction, these patches usually lack the typical silvery scales. Instead, they just look smooth, deep red, and they can be intensely painful or itchy.
And then there's a form that's defined by white blisters. Pustular psoriasis.
Right. This is a type defined by pustules. These are small blisters filled with non-infectious white pusters, and they're surrounded by red, inflamed skin.
Can it be all over the body?
It can be. It can be localized, affecting just the palms and soles of the feet. We call that palmar plantar pustulosis. Or it can be generalized, spreading across the body and, potentially causing systemic symptoms like high fever, chills, fatigue.
Wow. Okay, and finally, we have to mention the rarest but most critical type, the one that requires immediate attention.
Erythrodermic psoriasis. This is a true medical emergency because it affects the majority of the body surface, sometimes 90% or more.
90%.
The skin becomes extensively red, it sheds in sheets, and it's profoundly painful. And it's an emergency because when the skin barrier is that compromised, the body loses its ability to regulate its temperature and its fluid balance, and that can lead to potentially fatal complications.
That is incredibly serious. So how does a doctor actually diagnose this?
Well, it usually begins with a dermatologist's visual evaluation. We look for those characteristic plaques, we assess the medical history for any triggers or hereditary factors, and in cases where it's not clear, we might do a small skin biopsy.
And the biopsy is the final confirmation.
It is. It shows that dramatic hyperproliferation and the immune cell infiltration right there under the microscope.
And the symptoms aren't just the plaques, right? While the itching and burning are severe, I've read that there are also these distinct changes in fingernails and toenails.
Yes, nail involvement is a huge clue. It affects nearly a third of all patients. You want to look for pitting these small, pinpoint depressions in the nail plate.
Like little dentists.
Exactly.
Right.
You might also see discoloration, thickening, and something called onycholysis. That's when the nail loosens or lifts up from the nail bed. And these changes are often mistaken for fungal infections, but they're actually markers of the autoimmune process.
Okay, this feels like a perfect time to really clarify this for everyone listening. Psoriasis versus eczema. They both look red and itchy, but they are fundamentally different.
Absolutely. The root cause just separates them completely. Psoriasis is an autoimmune disease. It's driven from the inside out by those aggressive T cells. And you get these thick, well-demarcated, scaly plaques, typically on the extensor surfaces, so the outsides of your joints, like elbows and knees.
And
Eczema, or atopic dermatitis, is primarily a weakened skin barrier. The skin is leaky, it lets irritants in, and it usually presents as dry red spots that might weep or crust over. And you'll classically find those on the flexor surfaces like the backs of the knees and inside the elbows.
That's a great distinction. Now, when dermatologists assess how severe it is, they use something called body surface area, right? BSA.
Yes, that staging dictates the whole treatment philosophy. So mild psoriasis is less than 3% of the body surface area, which is roughly, 3 times the area of your palm.
Okay.
Moderate is 3 to 10%, and severe is anything over 10%.
So what's the practical difference for a patient who's at, say, 2% versus one who's at 5%?
The whole conversation shifts immediately. A patient with mild psoriasis is usually just treated with topical creams, ointments. But once you cross that line into moderate, 3 to 10%, it's usually not manageable with topicals alone.
And then what?
Then the physician has to start the conversation about light therapy or internal systemic treatments. And severe cases, over 10%, almost always require systemic intervention just because of the massive impact on quality of life.
So we've established the genetics, up to a 50% chance if both parents have it. But, genetics only loads the gun. What are the key environmental triggers that actually pull it?
There are several really powerful ones. Stress is, it's arguably the biggest lifestyle factor. Chronic stress releases stress hormones, particularly cortisol, and those are inherently pro-inflammatory. They just fuel the autoimmune fire.
We mentioned infections earlier.
Right. Infections like with strep throat and gut-teat psoriasis are huge accelerants.
What about a physical injury, a cut or a scrape?
That ties into this fascinating thing called the Koebner phenomena. This means a physical injury, a bad sunburn, a cut, even intense friction, can actually trigger a new patch of psoriasis to erupt in that exact spot weeks later. And of course, certain common medications like beta blockers or lithium can trigger flares. And we know that lifestyle choices like smoking and excessive alcohol are major inflammatory triggers too.
So the knowledge that this is a chronic systemic inflammation, that's the real so what moment here, isn't it? It means the consequences of psoriasis are so much more than skin deep.
Absolutely. The constant low-grade systemic inflammation from those circulating cytokines, it doesn't just stay in the skin. It impacts the entire body. And we see 3 major long-term risks.
Let's start with the joints.
About 30% of patients will develop psoriatic arthritis, or PSA. This is a separate autoimmune attack on the joints, and it causes pain, stiffness, swelling, especially in the fingers and toes. and it can lead to, significant debilitating joint damage if it's not managed aggressively.
And if those inflammatory signals are always flowing through the blood, how does that hurt the heart?
Well, those cytokines like TNF-alpha, they damage the endothelial lining of blood vessels. When that lining is perpetually inflamed, it just accelerates atherosclerosis, or the hardening of the arteries.
So there's a real cardiovascular risk.
The very real risk. Patients with severe psoriasis have an increased risk of serious cardiovascular events, including hypertension, heart attacks, and stroke.
And this chronic inflammation is also linked to metabolic health, right?
It is. There's an increased prevalence of metabolic syndrome, which is that cluster of conditions: obesity, high blood pressure, high blood sugar, and abnormal cholesterol. The inflammation connects skin health directly to these really serious internal health challenges. And of course, we can't minimize the severe mental health burden. The visibility of the disease leads to high rates of anxiety, depression, and social isolation.
So with all this complexity, what is the goal of treatment?
The goal is always multimodal. We're trying to minimize inflammation, slow down that cell production, and just alleviate discomfort through layers of different therapies.
For mild and moderate cases, I assume we start with the simplest tools, topicals.
Exactly. The mainstays are topical corticosteroids to rapidly reduce inflammation, and vitamin D analogs like calcipotriene, which specifically act to slow down the hyperproliferation of those skin cells.
What else is in the toolbox?
Other useful agents include retinoids, coal tar preparations, salicylic acid to help peel off the scales. And for sensitive areas, where long-term steroids are too risky, calcineurin inhibitors are often the safer choice.
Okay, so once topicals aren't enough or the disease gets worse, doctors start looking at systemic drugs. These sound a lot more aggressive.
They are. The older systemic treatments like methotrexate and cyclosporine, they work by suppressing the immune system pretty broadly. They're effectively just applying a brake to the whole inflammatory process.
They sound effective, but with a downside.
They're effective, but they come with significant trade-offs. They require close, regular monitoring of the liver and kidneys to make sure they aren't causing internal damage, which is, a major commitment for the patient.
So if the older drugs suppress everything, how do the newer drugs, the biologics, work differently?
Biologics represent a real revolution in targeted therapy. You can think of methotrexate as kind of a blunderbuss, just broadly suppressing everything. But biologics are like extremely precise cruise missiles.
Oh.
They're injected, and they fly straight to those specific cytokine signals we talked about, the TNF-alpha, the IL-17, IL-23, and they just neutralize them. So they're highly effective at shutting down that overdrive switch for cell growth while having a much less broad impact on the overall immune system.
So targeting the specific molecular cause leads to better outcomes with fewer side effects. But I'm guessing that regardless of the drug, the foundation of management is still lifestyle.
Oh, absolutely non-negotiable. Stress management is paramount. Things like mindfulness, yoga, consistent exercise, they lower cortisol, which literally reduces the inflammatory fuel.
And skincare?
Daily, gentle skincare with fragrance-free products is also essential. You have to focus on barrier repair using ingredients like ceramides, glycerin, or hyaluronic acid.
And I'm sure diet plays a direct role in inflammation, too.
It does. Adopting an anti-inflammatory diet, one that's rich in omega-3 fatty acids from fatty fish, almonds, leafy greens, that can help mitigate the overall systemic inflammation that fuels the disease.
Our sources also pointed to some specific adjunctive care options, natural ingredients that can help soothe symptoms alongside a medical plan.
Yes, we see things like aloe vera gel and coconut oil used for moisturizing and reducing mild inflammation. Warm baths with Epsom salts or oatmeal are wonderful for softening those thick scales before gently removing them. Even moderate controlled sun exposure, just 10 to 15 minutes, can be therapeutic.
And for targeted topical relief, our sources gave some examples of products designed to handle the active symptoms.
They did. Recognizing that barrier function is so key, you look for creams like a dermatitis cream, which might use colloidal oatmeal, calendula, chamomile, all known for their anti-itch and soothing properties. Or products like an elixir 16-in-1, which leverages things like manuka honey and aloe vera for deep hydration and anti-inflammatory action. These products really show how patients have to protect that compromised skin barrier.
This has been a really necessary deep dive into a very challenging condition. I think we've established that psoriasis is a chronic, T-cell-driven rapid cell turnover disorder. It has 5 distinct manifestations, and it's heavily influenced by that interplay of stress and genetics.
Hmm.
And that early diagnosis and a comprehensive treatment plan, one that balances medicine with lifestyle, are just essential for controlling flare-ups.
And while permanent skin damage like deep scarring is pretty rare, chronic, uncontrolled inflammation can certainly lead to long-term pigmentation changes. And this reality just underscores the necessity of controlling the disease aggressively, not just to clear the skin, but to protect your overall health.
So, with the understanding that the central threat here isn't the plaques themselves, but the chronic systemic inflammation that fuels them, consider this as you move forward. How might future treatments evolve to tackle the biggest associated risks like cardiovascular disease and metabolic syndrome by focusing on systemic inflammation reduction in the body as a whole, rather than just treating the visible skin lesions? The connection between the health of our skin and the health of our heart is far deeper than we ever thought.